This is Urban Health Today, and I'm speaking with Dr. Ali Jannati, Director of Cognitive Science at Linus Health. He's here to talk about how care teams can utilize person-centered tools to identify and track treatment priorities for patients at risk of or living with mild cognitive impairment, Alzheimer's disease, and other forms of dementia. Thanks for being here today, Dr. Jannati.
Thank you, Tamara.
First question, usually I ask about your background, but we'll circle back to that. What does person-centered tools, what does that mean?
So most of the standard cognitive and functional scales that are being used today for clinical and research purposes, they provide a standardized snapshot of the patient or participant's cognition and function. But most often they don't capture the aspects of their life, their daily life, their sense of purpose in life, goals, and priorities in a personalized way. So personalized tools such as Epsom or electronic person-specific outcome measures capture the individual priorities, areas of life and brain activities essentially that are the most important to that individual patient. So they allow us to provide a much more personalized care rather than just looking at some standardized score that might provide statistical significance in a clinical trial, but they don't necessarily capture what is the most important and what matters the most to a given patient.
And just for comparison, what sort of measures do the standardized scales look at?
So in the cognition space, there are a few main cognitive domains, such as speed of information processing, executive function, which is a really large umbrella of cognitive domains, look at any kind of thinking, problem solving, dealing with novel situations, working memory, the ability to maintain and manipulate information in our mind, task sequence, inhibition of impulses, etc. Then we have visual spatial abilities, how we can envision, imagine, memorize, and construct visual spatial components in our mind and on the screen or on paper using drawing tasks, for example. And then control of motor function, which has a connection to perceptual function as well. And these cognitive domains capture different aspects of the brain function, but they don't necessarily translate to the individual activities that are personally meaningful to a patient. On the functional scale, they might be asking the patient to provide answers. Well, are you able to move the way you want? Are you able to have meaningful conversations? Are you fine doing your own shopping, managing your finances, etc.? And they are very useful, but they provide a very kind of composite and standardized score rather than looking at individual areas. So in an ideal situation, we would capture both the standardized score, for example, for the statistical significance of some clinical trial intervention. But if we don't capture the personalized aspect, many of the important functions that are important to that person individually may not be captured, may not be shown to improve or impacted by the disease.
So asking a person about their shopping might not be useful if the person doesn't do their own shopping, in other words.
That's exactly right. Or a patient might have a special interest in golf or gardening or following movie plots or reading novels, etc. And those priorities, of course, vary across individuals and cultures.
Please talk about your background and your work with Linus Health.
Of course, I'm a physician by training and a neuroscientist, currently serving, as you mentioned, as Director of Cognitive Science at Linus Health. My background is between cognitive neuroscience and clinical research in neurology with a focus on digital health innovation. In my role, I oversee our clinical investigations, our scientific dissemination effort. I also provide medical and neuroscientific input for our various digital cognitive assessments and capabilities of the Linus Health platform. Um, in relation to the Epsom specifically, our team also helps guide initiatives and technologies that are aimed at understanding what really matters to people and patients when it comes to their brain health and how we can better reflect that in both clinical and research settings.
So you talked about the Epsom tool. So how does this approach differ from the standardized cognitive assessments?
That's a very good and probably the most important question. So Epsom flips the script essentially from scores about you, whether they are about your cognition or function, to goals from you. So rather than we asking questions about you, we ask you as the patient or participant in a clinical trial to tell us in open-ended free text responses across 5 domains. And those 5 domains are daily tasks, enjoying life, personal relationships, thinking skills, and the patient's sense of self. And then Epsom lets the patient pick a personal top 5 across any of those. They can be from the same area or across these 5 domains, and then rates his or her confidence on each of those priorities from 1 to 5. What that allows us to do is then trend and track those confidence levels longitudinally from 6 months ago, from a year ago, and into the future. We can track the patient's confidence in the specific areas that they prioritize when it comes to their brain health. And this workflow is intentionally simple. So it's a brief assessment. It doesn't take 30 or 45 minutes. It might take 7 to 10 minutes. And it has basically 3 main steps. Define those priorities, prioritize them, and then score your confidence. And then as the last step under the hood, we use natural language processing techniques to organize and extract the themes from those patients' free text responses at the scale, which then lets clinicians to see patterns without reducing people to a single composite, for example, on a cognitive test.
How did you come up with this? Where did when did you make this shift? When did this realization hit you that the
So
different
this tool was actually pioneered by my colleague, Dr. Sina Sanders in the UK. They were several PROMs or patient-reported outcome measures, but they were most focused on essentially templates or domains that were given to the patient rather than providing capturing free text responses from the patient. And Dr. Sanders and her colleagues in the UK did a study across 6,000 participants in the UK. They extracted the themes of those individualized responses and summarized them into the top 50 or top 100 across those 6,000 patients, and then looked at the pattern of those themes. And it turns out there are emerging patterns. They, of course, vary from individual to individual, but and from culture to culture, as we have shown in the recent paper in the US population. But the individual themes allow us to both evaluate, but also track those individual priorities as well as competency score. And that was based on the fact that there was really no such tool at the time. There was no digital tool or certainly no pencil and paper tool that really did all 3 things: defining them, prioritizing, and then rating their confidence.
Hmm. Well, your study revealed fascinating cultural differences between the US and the UK populations. So that the US participants prioritized driving and managing finances more, while UK participants emphasized volunteering and gardening. How do these variations impact brain health care delivery?
So they reflect important differences that can be and should, in fact, directly impact the way that care is provided across these countries. For example, as you mentioned, in US clinics, we as clinicians may prioritize driving safety counseling using digital cognitive assessments such as Linus Health tools that can predict risk of driving or failure at a driving evaluation in the near future. Or we might prioritize providing financial planning support for patients that select those priorities as their top five. Whereas in the UK, clinicians might emphasize social connection, social support, walking groups, or gardening programs, just to give a few examples. But this really shows that the culture and the social environment of a patient really shape what independence and a good life looks like in the mind of that individual patient.
So what does that look like? So um my my father has cognitive impairment,
Mhm.
and his driving is important to him. He identifies that in the assessment. How do you then implement Linus's driving safety tools?
So that's still, I should say, in development, but because the array of our tools evaluate visual search, visual scanning, executive function, task switching, hazard scanning, and we have different assessments for all of these cognitive functions. If we, for example, administer Epsom as well as our digital cognitive assessments to your father, we can capture the metrics that have been shown to predict a successful or less than average, less than expected based on the patient's demographic group performance in executive function and a specific neurocognitive metrics that correlate with an individual patient or your father's driving ability. After we establish a baseline, if the digital cognitive assessment do not provide any kind of red flag, we recommend retesting at regular intervals, maybe every 6 months or every 12 months if there was no indication of any impairment. But if there was, and
Mhm.
if any of those metrics and subscales of our DCAs provide any kind of red flag or indication of cognitive impairment, we would actually refer your father for a full driving evaluation. We
Oh,
would
wow.
also use the Epsom tool to establish a baseline, capture your father's confidence in driving, and then based on the subsequent evaluations and testing, we can see is he maintaining his current confidence, how much drop in his confidence in driving, for example, has been um, occurring due to the any kind of underlying disease.
How can healthcare providers use the person-centered tools in your study to address the varying priorities and values of different cultures when designing brain health interventions?
So one of the most valuable aspects of Epsom is that when we are capturing patients' own priorities, we essentially incorporate those cultural and individual localities into the responses. And in a, for example, busy urban health system, um, the success of implementing tools such as Epsom comes down to making the patient's workflow as easy as possible. So from the start, and not something that you get to the at the end of some disease process. Uh, a patient fills out Epsom, for example, on their phone or on their tablet. It doesn't have to be in a clinic. They can do it um, at their own leisure before they arrive for any kind of clinical visit. And by the time they walk into clinic, it can be a major health system, or it can be a memory clinic, or it can be primary care setting. Their top five priorities at their confidence levels are already captured in the electronic health records because all of our tools and digital cognitive assessments have full integration with EHR. So the clinicians can already see those priorities and they can see the confidence scores and they can be flagged if anything has dropped since the last time, the previous 6 months or previous year that the patient completed the Epsom tool. Now, when the clinician sees those ratings and those confidence scores, especially if they have longitudinal assessments,
Mhm.
they're not starting cold, basically. They've got one screen snapshot, but they also got the trend from previous evaluations. They can see what matters most to this patient right now, uh, what is changing, if anything, and there are some suggested next steps or referrals. Based on the level of changes in the competence scores, we can engage the rest of the team, whether there are specialists, occupational therapists, social workers, pharmacists, etc., can essentially pick up those threads and act. And because you mentioned health systems, we think at the population level, leadership of health systems can also use these tools to see patterns that are emerging across their patient communities, any neighborhood, any special geographical locations. And for example, they might see that driving confidence is falling faster in one area, whereas social engagement might be dropping in a more isolated community. And we think that really helps them target and direct their resources.
Hmm. Your US cohort of 764 older adults showed that individuals with self-reported cognitive impairment felt significantly less confident in maintaining their top life priorities. So, how can this confidence metric be practically used by primary care physicians to guide early intervention strategies?
And that's a very important point because we think that the confidence is really an early warning light
Mhm.
on the patient's dashboard, essentially. So, as you mentioned, people who reported a neurodegenerative disease had a median confidence score of 21 versus a median of 24 versus for those who did not have such a diagnosis. We think any drop of confidence of two or more, let's say driving confidence falling from 5 to 3 or lower, we think should trigger targeted steps. Whether they could be vision or hearing checks, medication review, especially anticholinergic burden, occupational therapy, speech language pathologist referral as appropriate, and driving evaluation, as I mentioned. For patients who might show more precipitous or more significant drops, they might be requiring some care partner support, which means the clinicians and social workers need to coach and provide training to caregivers, which Linus Health also provides, as well as there might be some environmental tweaks or safety considerations for patients who might be progressing beyond the stage of MCI. And then we recommend retesting within a few months, especially if there has been a significant drop in less than 3 months would be ideal, but definitely between 3 to 6 months. And if the confidence stabilizes or improves, that means whatever intervention or disease modifying treatment or lifestyle interventions were being implemented, it means the plan is working for that individual patient in the specific area that they were most concerned about.
So, Linus Health puts together care teams for the patients.
We have a functionality that provides support and training for care partners. We also collaborate with systems such as Brook Health that are specialists in chronic care management because we see Linus Health as an end-to-end brain health platform rather than just a digital cognitive assessment platform for early detection. That's where we started, but since then, we have now morphed into an end-to-end brain health platform. And I think our chronic care management and care partner support and guide enablement. So as I'm sure your audience knows, guide is one of the models that are being tested for dementia care. We provide full enablement of guide, which provides multiple aspects of care for people with cognitive impairment, from social determinants of health, providing support in their activities of daily living, in various aspects of their cognition and function. And then by using those by using those services, we think clinicians and patients and their families can really improve their care.
Speaking of families, out of curiosity, how do you include the primary caregivers at home in this process?
So when the uh, primary care visit happens, essentially the caregiver may be joining the patient. If
Hmm.
not, and if the clinician finds that the patient requires caregiver support, it's really up to the clinician to engage. If the caregiver is not already part of the care of the patient, we recommend encouraging patients to bring a family member, relative, neighbor, etc., someone who is intimately familiar with their daily lives. And then we can provide tools and support than the clinicians can convey to the caregivers. We think engaging the caregivers also is the best case scenario for improving the mental health and reducing the burden of caregivers.
Mhm.
Uh, because taking care of a patient with significant cognitive impairment can be very burdensome. It's also a lonely task and can be stressful. So we
Right.
provide training and support in as many as those areas as we can.
Linus Health CEO Dr. David Bates mentioned the study findings represent, quote, a fundamental shift in how healthcare providers and the life science companies evaluate treatment value, unquote. What would successful implementation look like in busy urban health systems?
In an ideal world, patients would receive messages either as text message or emails that they can just tap on a link on their cell phone or iPad or laptop, and they complete the Epsom tool well before, not months before, but maybe a few days before or a week before an upcoming clinical visit. Um, they complete the Epsom, they select their top 5 priorities, they rate their level of confidence, and those responses are uploaded to the patient's EHR. And now, when their upcoming visit happens, the clinician has a very good sense of areas that matter the most to that patient, how confident they are in functioning in those specific areas. And then we provide recommendations. So we have clinical decision support and recommendations based on both of our cognitive assessments as well as tools such as Epsom, as well as questionnaires that screen for depression, anxiety, other conditions. And then we provide actionable, personalized recommendation so that the clinician can guide the patient specifically based on those areas. Some of these functionalities are still in development, but in an ideal world, all of this would happen within a few minutes. The time of the clinician, which is very limited, is not consumed by capturing all of this information because we are providing them all beforehand and capturing them and recording them. But most of the patient clinician contact time is dedicated towards the reviewing of the recommendations, guiding of the patients, addressing those specific areas. And then when the patient again is seen for a follow-up visit, if they have a cognitive impairment in a few months, or if they're not showing any signs of cognitive impairment, maybe for their next annual wellness visit, that baseline Epsom tool has now established a very good kind of comparison level so that the next time the patient is seen, the clinician can look at the previous scores and say, okay, you were having some doubts or difficulty in following conversations on your social engagement, and then they can compare their current status to that previous status and see how it's going. And that provides a much more robust tracking of those patterns that might emerge in certain diseases and certain populations.
So now when you talk about an ideal world, are you talking about how it should work versus real world, or can you provide some clarity on that? Is there
Yeah, in an ideal
real
world
world
is
and
where
real world?
these Linus Health and similar digital tools are widely deployed across essentially all of our health systems. So
Mhm.
right now, Linus Health is already deployed in several major health systems,
Mhm.
but we are not there yet.
Ah,
We can reach many, many more patients so that they can benefit from these tools. And there are many more health systems that have yet to deploy these scalable digital tools.
as new Alzheimer's drug treatments become available, how might the Epsom approach help clinicians determine whether the therapies are providing clinically meaningful benefits to patients?
Thank you. That's such an important question, as these disease-modifying treatments are talk of the town, essentially.
Mhm.
So the clinical trials that showed the clinical effectiveness of these disease-modifying treatments showed some slowing of decline in those composite cognitive and functional scales that we talked about. but they don't track confidence in any personally meaningful priorities or activities. By using tools such as Epsom, clinicians can see whether any of those treatments is helping a patient maintain their independence longer in any or some of those areas, or at least causing a slower decline, or in some cases, it might in fact improve those specific areas. And that is virtually impossible by using standardized scales, because when we use a composite score, let's say, such as FAQ, Functional Activities Questionnaire, or CDR, Clinical Dementia Rating, the overall score is such a crude measure because it's a combination of so many different things that doesn't allow visibility into any changes that might be happening, any positive changes, let's say, that might be happening because of those treatments. Whereas Epsom allows a much more granular, much more personal picture of that individual patient's functioning, but not necessarily overall functioning in the specific activities that they care the most. And that might allow life science researchers and pharmaceutical companies to actually show personally meaningful treatments by using Epsom, whereas those standard tools might miss some of those effects.
That's interesting. So you haven't seen cases of the placebo effect where the individual is taking the medication and they feel more confident because they feel the medication is working?
That's always a possibility in neuropsychiatric diseases, but
Hmm.
one important aspect that can help tease apart placebo effects from real therapeutic effects is
Hmm.
the durability and longevity of
Ah.
the effect. So most of the placebo effects, which can be substantial, sometimes 40%, sometimes 60%, for example, in treatments for depression and other conditions, might be due to placebo. But what happens is that over months, especially over periods of, let's say, longer than 3 to 6 months, it's very unlikely for a placebo effect to last that long.
Oh.
Whereas by capturing those specific areas, let's say one of those confidence scores in Epsom is showing some improvement, whereas the other one may not be showing. Placebo effects don't necessarily differentiate between the specific areas. They are more likely to show an overall improvement. Let's say if I'm feeling overall better, I'm much more likely to, let's say, rate my confidence better across
Mhm.
those 5 domains. Whereas a real effect, not only it's more likely to be longer lasting, it's going to be a specific to maybe two or three or one of those areas, but not the others. And that makes it more likely that the effect is a quote unquote real um, rather than a placebo.
And with the Epsom, the clinician will be able to assess that properly.
That's right.
Nice. Looking ahead, how do you see this person-centered assessment approach scaling across different healthcare systems?
As I mentioned before, I think the key to scaling is to keep the workflow simple enough um, so that it can fit really anywhere. Any internet connected device, really, whether a cell phone, tablet, or computer, um, is good enough to use tools such as Epsom. But they're smart enough to add value anywhere across different healthcare settings. So as I mentioned, Epsom is a very short, it's digital, remote friendly. So you can imagine it can be done in all kinds of settings, primary care, memory clinics, long-term care, assisted living facilities, without adding much more burden to the visit that the patient might have with their clinician. Um, Patient might complete it, as I mentioned, at home before any clinical visit or in the few minutes that they are in the waiting room. And we think the crucial value is gained when we start connecting the dots, when a person's priorities are captured in their own words, and then we extract themes from those pretext responses and rate their confidence. We give the clinicians a robust way to both capture and track their confidence in the areas that matter them matter to them the most.
Yeah, doing it in the waiting room before you see your primary care physician makes the most sense because I was just thinking how primary care visits have become so short. They're like maybe 15 minutes. You spend most of your time waiting for the clinician than actually seeing the clinician. So that approach makes more sense or at home doing it.
Exactly.
Can't see doing it side by side with the clinician that they're just too busy. They're just too pressed for time.
Sometimes patients might desire some privacy to think a little bit because it's different from a simple cognitive task. We are asking them, for example, one of the areas is their sense of purpose in life and how confident they are that they are pursuing their life purpose. Do they have a good feeling about their um, sense of themselves, etc. And these are sometimes questions that might take a little bit of thinking. So it might take a few minutes. That's why it's um, much more convenient for patients to complete them in a less stressed environment, in a more private settings, even at their own home.
And Linus, of course, would advise the clinician, like we advise you to give this to the patient before the encounter. Do you make sure to say that to them so that they know, like, okay, this has to be done beforehand because you don't want
We,
a situation where the clinician, it's like an afterthought and they do it kind of like social determinants of health, where
right.
it's done by the medical assistant, and it's like a quick, 5-minute thing, and you don't have time to really give it thought.
Yeah, exactly. So in most of our health systems that we are deployed, we have standardized batteries. So when they complete some of our digital cognitive assessments, we can add the Epsom to the battery so that it automatically shows up, or we can provide trigger and reminders through the EHR. Of course, we don't want to force the way clinicians practice in terms of taking care of patients, but we provide recommendations whether to complete it beforehand, which might be preferable, or in the waiting room if the patient forgets, if they didn't have time, if there were issues, they couldn't access their email, etc., they didn't get the text or they missed it, they can still do it in the few minutes that they're in the waiting room.
Is this assessment smartphone only? Because I'm thinking, some people have like those little jitterbug phones where it's the push button. Like my dad has one of those flip phones with the push button. He wouldn't be able to do something like that on his phone because he doesn't want a smartphone.
Yeah, so if it's on the phone, it has to be a smartphone, unfortunately. It doesn't work with flip phones, but um, any kind of tablet, which we also provide for cognitive assessment, the same tablet that medical assistant can use for cognitive screening using, for example, Linus Health core cognitive evaluation, the same iPad can be used to complete EPSAM, or any kind of Android or Windows or Apple operating systems.
And you should probably consider a paper version also, just, for those. Just a thought. Anyway, thank you very much, Dr. Jannati. I really appreciate your time today and your insights into this area. This is really fascinating stuff.
Thank you, Tamar. Thank you for the opportunity.